Just I want to show you, this is severe internal rotation. This is a snip. It was love from the first sight. At first sight, she was one of the most beautiful girls 4,000 years ago, and she fell in love with snip. Severe internal rotation deformity. You don't have to correct it. This was the love story. I forgot just to tell you that he was the richest man on earth at the time. Just I forgot. So. We are going to talk about the site of the deformity. Is it isolated deformity? The assessment, rotatory knee instability, and surgical treatment. Where is the site of the deformity? You have a rotational deformity, and you have to decide whether intra-articular, extra-articular, ligamentous, or all of them, or any combination. You can have intra-articular, extra-articular, ligamentous, purely intra-articular, purely extra-articular. I didn't read that in the books. These are the tips and tricks which I've been facing in my practice. I'm not going to speak about the rotational deformities of the limb children, common and extra-articular, and I know my colleagues will cover all the topics. But this is the real rotational deformity. It's 90 degrees internal rotation deformity. And you see the knees on both sides. Looking just laterally, and this is medially. This is clinical assessment, because the patient cannot walk. He's bedridden. And look to the assessment. It's ape-like walk, inserted syndrome. You see the rotational deformity. And this is intra-articular knee deformity. This is ball and socket joint. I don't know if you've heard about ball and socket knee joint before. It's very difficult to correct even this intra-articular deformity, because you have congruous incongruity. Post-traumatic rotational deformity, it's totally different. If you are doing trauma, you are going to face post-traumatic rotational deformity. Is it rare? If you are doing trauma, I don't know, the trauma guy is here. Is it rare? What would you think? Raise your hands if it is rare. Rare. It's common. But the people deny it. We'll see. In cases of post-traumatic trauma, the site of the deformity is the fracture site. So if you want to correct, you can correct it from the fracture site. Sometimes you can correct it from another site, but usually we do it exactly the site of the trauma. Physical injuries, traumatic cases. You see the knee here. See the internal rotation deformity. Look to the knee. Of course, we have valgus also. Look to the X-ray, long-standing X-ray. See the lower femur, the upper tibia, oblique joint. So this is an intra-articular deformity. Is it ligamentous? Yes, we have important ligamentous component. You have also bony or articular problem. Rotational malalignment after intramedullary kneeling. You know how far is the problem? For the femur, 20 to 33% have rotational deformities, more than 15 degrees. if you think about the whole deformity, it might be 70% of the cases. And tibial, 19 to 41% of cases. I'm still revising for journals, papers coming from level 1 trauma centers, and still they have the same instance. They said, yet we have different ways of diagnosis, and we are going to do so and so, but still they have the same problem. But as usual, malrotation did not affect the functional outcomes. This is usual. Why it's usual? Because, you know, if you want to make something looks better, you choose the short follow-up. So the user choose 2 years, 1.5 years. Of course, 1.5 years won't do anything, but we didn't see papers with 20 years follow-up or something. Remember, after nailing, there is no way back. You have to take the patient to the operating theater again. But still, nailing is the primary treatment of fractures in most of the centers or all the guidelines. The site of the fracture is the site of the, if you want to derotate it, you have to put it, you have to derotate at the site of the fracture. In this case, you know, non-union at this site with nailing, and you remove the nail, and we did derotation at the same time. You can assess the problem with nailing and plating or something. You cannot assess the derotation immediately because the patient cannot do weight bearing. But in our cases, when we do external fixator, you can assess the derotation or the rotation immediately after the operation. The patient was operated the day before, and we let him walk, and we see the rotation. And if you have internal rotation, external rotation deformity, you can correct it, no problem at all. 1 millimeter per day, we change the frame. So is it only rotational deformity? No. I can hardly see a purely rotational deformity. No. Why on earth the deformity choose one plane? Why? We invented, you know, or this is our imagination, the planes, but it's not reality. So you can see the rotational deformity in different positions. And the coronal plane with different degrees of rotation, it's different. And this is how it is difficult to assess. Why it's difficult to assess. In this patient, you see the rotational deformity, but you have valgus, you have other problems. This is Digvé-Melchior-Clausen syndrome. It's not an isolated deformity. You have varus, you have other problems. So you cannot say it's just purely rotational problem. It can be secondary rotational problem. This case of physeal injury, you see the way she walks. She has ligamentous laxity, long-standing deformity. Can give you this picture. I'm not going to talk about the assessment, or just the tips and the tricks, because you're going to hear it many times. Again, we do CT scanning or something, but I don't know, just in my practice, it's not that helpful. You know, I have a case in the last 20 years. I've done only a case of derotation. You know, the girl has severe internal tibial torsion after birth and was follow up. I told her I have to wait till the age 10 years for spontaneous correction. And they came, they were not living in Egypt, so I corrected the left side at the age 11. And she left home, And she came after 3 years. At the age 14, I found the other side fully corrected. 100%. So you have to be hesitant in these cases to correct the deformity. The problem with the assessment that still we are living in the 2D world. The 2D world is nonsense. Again, we created the 2D ideas. We are living the world of 3D, perhaps 4D, 5D, and still coming the 6D. So you can use the 3D printing. I know it's very expensive in some places. It's cheap in Egypt. I don't know why. I don't know. You can send the patient to Egypt. So we need more to talk about the 3D. 3D is very important. Now, something is called rotatory knee instability. This is for adults. Rotatory knee instability, like this patient. And it's related to ligamentous injuries, anterior cruciate injuries. And I'm not going to talk about it, but you have to put that in mind. This is ligamentous instability, which gives you the rotational deformity, and you have to manage with the ligamentous problems. I'm leaving that to adults, knee surgeons. The treatment, you know all the conventional treatment. You do an osteotomy and derotate and put a plate, you put a nail, or whatever, submuscular plate. This is acute treatment. And people say this is safe correction. You see this paper by my friend Kevin, and they did release of the common peroneal, and they put, there is nothing called safe operation. Yes. We have to remove this expression. 8 cases done with short follow-up, but it is safe. And 1 case has serious complication, but it is safe. This is almost in all the papers. I don't know why everybody wants to say, I have a safe operation. There are no safe operations. What to do in such a case? Just severe internal rotation deformity. Guided growth. People use the guided growth and say it's marvelous, can correct all the rotational deformities, and it is safe operations and very successful. Okay, we did, this is guided growth till we got overcorrection, okay? These are ordinary plates, they are not plates. But the rotational element, it was not corrected. We corrected the varus, so we did osteotomy, acute osteotomy at removal, and we corrected. So we are not dogmatic. If you don't have that treatment, you don't have one way of treatment. The recurrence of the deformity, the rotation comes back. This is usual in these cases, and we did again the rotation osteotomy. See before and after. So you can do guided growth, rotation osteotomy, external fixation, whatever you want. You don't have one choice, you have many choices. Severe internal rotation deformity. This is 180 degrees rotational deformity. We did corticotomy and derotation 1 millimeter per day. It's exactly like lengthening, 1 millimeter per day. You see the derotation, and this is the construct for derotation. Yes. And this is before and this is after. Look to the bottom. If you are doing the same job, you can examine the patient 2 months after the operation, 3 months after the operation, 4 months after the operation. And the patient told me, I still have internal rotation. You can correct it. No problem. Without anesthesia or analgesia, no problem at all. This is the construct of changing the rotation. In conclusion, the site of the deformity is very important, intra-articular, extra-articular ligamentous. I can't say that I've seen isolated deformity. Assessment, you have to think 3D. Rotatory knee instability is there, and you have to think about it. And surgical treatment, you have many options to choose. Don't think about one option. No one is the best. Is it safe surgery? There is no safe surgery. And gradual postoperative correction for severe degree of rotational deformities. If the deformity is beyond correction in your mind, it's 180 degrees rotational deformity, 90 degrees deformity, this is very easy if you do it gradually 1 millimeter per day. So, thank you.